Okay. Uh, Hello, everyone. And I wasn't expecting to be the first one to present, but here we are. So today I'm going to share a work that we have been doing for at least 3 years, for the past 3 years, actually more than that, but it's a work from a lot of people. I'm just here presenting what the others are doing. So in Ethiopia, we have this one plan, one budget one report strategy where everything that happens in the country hap has to be aligned with one plan. And that plan has to come up with one budget, and then that one budget has to be collected. The M&D work has to be done in one report. So this one plan, one budget, one report strategy is about aligning coordinations where every partner, whoever wants to help, whoever wants to come up with any kind of interventions within the country has to align with the ministry's strategy to help or to contribute into the country. So this allows coordinated and aligned efforts throughout the country so that when people want to come, when donors, partners, and others are coming to the country, then they know there is a plan there and then they can contribute to that plan. The next is there is a unified national health strategy. So this one plan, one budget, one report allows a unified way of having interventions, having any kind of activities to be aligned with that strategy. There's a better for resource utilizations because everyone goes into that pool, that single pool of resources, and then that will be distributed easily. And there's also an easier way of doing the M&D work behind it. But there's also a challenge. That challenge is you when you plan, you need to plan for everything once. So you need to plan for everything at a single instance, and that's a bit of a challenge. So the planning process has these huge indicators that are prioritized by the ministry. So all the indicators that are prioritized by the ministry need to be planned at a single instance. So this is an Excel file that have been used for a while. This is a huge file. This is just a small chunk of it. And then using within this Excel file, there is this um, so if you see there is this baseline that they need to see for their planning, there are the eligibles that they need to manually enter, and there's also the target that they're setting up. So everything usually what happens is the populations, they enter the populations, the conversion factors for those population data is given to them through national standards. And then they need to enter the baseline themselves on the Excel file, and then the population on that Excel file, and everything is done on that Excel. So the problem is when you get this from each district, then you need to aggregate it, you need to align it. So this whole process is a bit of a lot of process which takes months to complete. So what we did was, since most of the indicators are already in DHIS2, we tried to have an app that can automate their work for them. So the first is we tried to integrate with the existing infrastructure. One is that there is already a DHIS2 knowledge base in the country. And the second is most of the indicators are already inside DHIS2. So we tried to come up with a way that can help them work within DHIS2 for the planning process. So the second phase that we did was we tried to coordinate with all stakeholders. So these are mostly the planning team and also the digital health team. So aligning with all stakeholders is helpful because this is a very critical phase of the ministry where each indicator is allocated a target, each indicator is also translated to a budget. So that will have a lot of implications if things mess up. And the final phase was we tried to implement it phase by phase initially, but the problem is you either have to go to Excel or you have to go through the digital because you can't have both. So for almost 2 years we tried to have both, but that was creating a lot of chaos. And last year during there was this decision to go all digital, and that was a bit of a chaos initially, but things started to move on, and it's really improving now, especially during this time, they're also planning now, and it's becoming better. So the key features of this app that we did was we tried to automate a lot of things, not just the aggregation part, but even within the baseline, within the population, everything is automated, which enables them to have at minimum as possible the errors. So we minimize the errors. All the data that is or that is expected is preloaded, especially with the HMIS data. So initially, because it was just an Excel and they were the ones that fill in the baselines, they used to go to different sources trying to get the data. Some use DHIS2 and other districts use existing Excel data that they have, and it was not aligned well. But now all the baselines that they have, most of the baseline at least, is preloaded with their existing HMIS data. So this will help not just the planning process, but the performance data as well. Because next year, if they don't improve, like input their actual performance data this year, they won't be able to plan for the next year. So it also helps in improving the data quality of the actual HMIS itself. So we also have a user-friendly interface because we cannot use the existing DHIS2. They have been using this Excel file for many years, and we cannot just shift the user interface to a different one. So we had to have a user-friendly interface that the users are accustomed to. And finally, the standardized national conversions. So within DHIS2, we had people entering the national conversion at the national stage, the conversion factors at national stage, and then being pushed to all facilities so that they don't even really need to bother about their conversion factors. And at the end, we also had printable formats and Excel formats for them to download their data. So how it works is first national users input national conversion factors. So those conversion factors, we have it as region specific. And then those conversion factors will be cascaded down. The app itself will cascade it down to all the districts within that region and all facilities below that region. So next to it, we also have national users inputting populations for districts. This is more of a unique requirement, maybe a unique requirement only for Ethiopia, but we want national users to input target populations for each district so that the districts won't really change that population according to their needs. The second is once these conversion factors are inputted at national scale and the population is there, then the eligibles are automatically calculated using DHIS2 because it has that feature within itself. And then the district users, because there is the HMIS data behind it, and then there is the conversion factor, all the eligibles are there now because of the population factors. Now the district users just input the target that they want to set. So they just need to input target in percentage. They just say, I want 50% this year, or 80% or 90% based on the performance that they had last year. And then based on the eligibles that they have this year, they just provide the targets. So nothing is really given to manual errors, especially the aggregation part. Now you don't need to collect thousands of Excel files to a central user and then do an aggregation based on that Excel. So this is still the app. Now we try to resemble the Excel as much as possible. So this is the app. What we do is we have the baselines here. So we have the baselines in numbers and in percents. We have both numbers and percent because it's easy for them to have that plan. So what we do is now if you see this is a dummy data, it's just a test instance. So for example, now car or LFP, they have their previous performances within the same screen, and it's not, they don't need to go to different screens to see their performance and then perform their targets. So they have their previous performances within that same screen. They have the eligibles. This eligible is just the population multiplied by a conversion factor that is set by that region. And then within the same screen, they also have that targeting percent that they set. So once they put 50 or 80 or 60, then their target will automatically be calculated. their eligibles are already calculated, their baselines is already coming. And then the moment they input this, then it automatically aggregates it up to the national level. So then we will check at national where whether it aligns with the country's strategy, whether it aligns with the plan that we have, and that will be very helpful. So the only input that they provide is this part. Most of the other inputs are already preloaded. Before, within the Excel, they have to input all their data. The baselines have to come up from different perspectives. And one additional challenge that we have is because the planning process, especially the aggregation part, takes a lot of time, it usually happens 3 or 4 months before the end of the period. So during the baseline process, they have their 9 months performance, and then they do that baseline, and then once the year ends, they need to redo that again based on for the full year performance. But now they don't need to do that because it automatically updates whenever they change their performance because it fetches it from the baseline. So we were able to have this perform very well. And there are some indicators, of course, which we do not get from the HMIs. So for that, we allowed them to enter manual ones. So if you see, like, for example, these ones and these ones, we also have that flexibility of allowing them to enter their own baselines if that indicator does not come from the eligible, I mean, from the HMIs. So these are the results. So the aggregation process, it used to take a lot of time for the planning, but even the director, the deputy director is here, who is Masood. So who was the one who made sure that the change between the two well, then it was good at the end. There is an improvement in quality and efficiency, not just on the planning process, as I told you, even within the HMIs, because what they're allowed to plan is based on their performance. Even the HMIs itself is becoming improved. The data accuracy is improved, better resource allocation because we know now it's automatically calculated, enhanced decision making because they are now real time. Whenever they enter their targets, we can see at real time their performance against it. So this is something that is really helping a lot. So the current achievements is that we allow DHIS2 to be streamlined with the planning. We have stronger data divisions, and next we want to have, of course, enhancements on it. We want to track quarterly their performance. This is something that we are planning to do, and this is all. Thank you.
Thanks very much for your presentation. Let's get ready for our next speaker. Just one moment. Site savers.
Testing. Okay. Morning, everyone. So I'll be speaking to you around advancing NTDs, data management and reporting within DHIS2. My name is Christian Wosu, and I work with Site Savers as a regional technical lead within the EPID unit, where we support digital systems across the countries where we work in Site Savers. Basically, this presentation is focused for Nigeria, where we have tried to do some where we deploy a number of digital systems to support entities. Now, basically, what is entities? Before I get into what entities are, my presentation will look at what the challenges has been around entity data management program, the solution that we have presented, and the results and what we're seeing, and what the future and the skills are like. Entities generally is neglected tropical diseases. It's one of those diseases that's not really very prominent, very known, or very all the support that it's really required to have. But it's one of those diseases also that has lots of affected billions and billions of people. As of 2022, WHO estimated that about over 1.6 billion people are living with NTDs across the globe. And it affects where people have been affected are being impoverished and underserved communities, and causing lots of devastating health and socioeconomic consequences. Now, what's the challenge in NTDs around data management? It's because of its intervention is community-based and kind of looks at a lot of people who require treatment, interventions, medicines are being distributed to kind of help prevent these diseases, right? So over the years, one of the things we've seen around the challenge is the fact that there have been fragmented data silos that we have seen, different partners working in different places with different systems and supporting different systems. And at the national level, there has been just like one big spreadsheet Excel where all kind of data goes in, and sometimes it lies in different systems in different persons. And as time went on, as people leave from the ministry, you find that lots of these data are not actually available. There's nowhere it's available. So that became one big challenge that we had to start looking at how to address it. And then again, lots of the data that are from lower level are paper-based. They are really paper-based. They are not anywhere after the interventions. After a couple of years, you find that this data is missing. There's nowhere to come back to find historical data to be able to make certain decision and understand what the trends has been like. And then also, there's been very limited real-time monitoring and feedback from the entire system. So you can really make decision immediately. You will have to wait to get information from different places. You probably have to wait for months when you write emails. How can we be able to get this information? To really limited to identify and respond to emerging challenges in a very timely manner. And then also there were issues around data quality in terms of sometimes you can't reconcile what has happened in the previous year with the current year, and all of those silos kind of created those challenges. And then sometimes you also find that incomplete reporting across the different places. Then also, because of these different systems, partners and everyone started looking at, okay, how can we work on all of this? There's no way there's like an interoperability of all of the information, where they are coming from, how do we bring them all together? So those were things that eventually from our own end and from Sightsever's end. So what we tried to do is to work with the ministry, and we kind of began to look at setting up a system that would be used for, I kind of begin to bring everything together. And what did we do? We leveraged the DHIS2 system, where we set up this to address the challenge, and implemented this solution for entities. And what we're looking at was more of a real-time reporting when interventions are happening. It's a campaign-based intervention, right? But we wanted to see how would this look like as interventions are going on. You are able to pick up all the issues and all of that. And then secondly, we also wanted to see, we have thousands of communities, settlements that needed to be reached. Sometimes we don't even know how many we need to reach in a particular campaign. So this kind of began to help us to look streamlined. So, okay, where do we be able to put all of these things in one place and provide that solution for the country? We worked with the country and we developed the system a couple of years, about 4 or 5 years ago, and then set up the system, started with a few places, and currently we have it's been expanded across we should be about 14 to 15 states now, thereabouts, heading to 20 states in Nigeria, where it's being deployed and then being used across the different states. And from what we have seen also is that there's been increased demand for its use. And then having come to that point, one thing we now began to discuss with the ministry is to say, now you need to own this system. You need to make this system a national system. You need to make this to become yours such that it's no longer partner driven. And if there is funding downtime, what happens to all of that? And that gave birth to a new discussion that the ministry now started setting up something, an architecture that is now beginning to look at taking over everything into that system and its house within the ministry and all of that. So we've been in discussions with the ministry, with HIS within country to see how all of that comes into one place. And it's going to be more like an entity repository. It's no longer in silos, it's no longer by partner driven and all that. So why did we choose DHIS2? Before DHIS2, we had piloted another system that we tried to see how that was going to work. And we realized that DHIS2 gives us that open source platform, that scalable architecture that would allow for government ownership, that would allow for customization of different approaches that is being within the country. And then also, because of its analysis system, it's easy for people to use, and there's already an existing system within the ministry where people use the DHIS, so, and also the data quality apps that are already inbuilt within the system and all of that. That was why we made those choices and said, okay, DHIS is where we will head to, and that eventually gave. So what's the results? One of the things we saw that there was an improved data accuracy. That's one thing that for us that stood out very well. So you could see that data accuracy began to change from places where you saw that there are things around. You find places where we have low coverages in terms, because we didn't really know what the denominator was at some point in time. And then we began to say that, oh, now this is what the denominator for this particular location is. And then that helped us to see where the true coverages are. And then also helping us to have a good kind of rely on the data that is coming in from there, and you're not seeing the data in Excel probably changing from time to time. And if there's any changes, you're able to use it within the system and to see where the changes came from, who made those changes, and helps us also. Secondly, also to look at a faster response timing. Initially, we could finish treatments. It takes us like 3-4 months. We are still trying to get treatment reports in, but at this timing, we are finding that, okay, yes, within 2 weeks, within 2 days, sometimes even within hours of reporting, you're seeing all the reports coming in and much, much faster. And then there's also transparency. It's not like waiting for someone to finish up and send, right? We'll begin to see transparency. And then also we'll begin to see things around positive impact in terms of the management capabilities. The ministry is beginning to say, see, this is now us and being able to do what we have to do the way we need to do it, and making everyone confident in the data that is coming in. And then also, next, having seen all of those things, we started looking at what was the plan, and which is what I had mentioned earlier on. So the future plan, we had actually we're looking at, because for us at Sitevas, we do a number of ComCare, and there's a lot of ComCare work going across the country. And so there's this kind of discussion around, okay, how do we integrate all of this back into DHIS2? There is the entomology aspect that's happening somewhere, and we have done within Sitevas, trying to bring all of that in, and also some global collaboration going on within the ministry to see how to bring everyone together, that partners should be able to come in to have a buy-in into the system and then be able to continue with what is going on, and then leveraging on what is actually available within DHIS2, and then also looking at scaling in terms of looking at a lower level integration where those from facilities could be able to use the mobile apps to be able to report rather than wait for using the desktops to be able to report. And then also building capacity building for the ministry and local health workers, and then look at improving interoperability. We're happy that we're seeing the files discussion around fire that's going on, higher levels of integration and interoperability, which we want to see. We'll be able to look at start discussing how the ministry can leverage on that platform to do all of those interoperabilities. So in conclusion, what we have actually looked at is the fact that we want to improve data management within NTDs because it's a very huge data elements that we have to be able to look at and then be able to see how to make sure that the ministry is able to continue using the system as interventions continue. Thank you.
Thank you very much. We have been having some comments coming online saying great presentations, thank you so much, and great ideas. So that's good. So let's get ready for our next speaker. How about Indonesia? Ready?
Hi, okay. Hi everyone. I'm Taufik Stompul. I am presenting from my college works, but because no one from Indonesia stay here so I can continue for this. So I will adapt and modify some language because on Indonesia context must be reliable with this too. So here it's about the integration, nutrition, maternal, child, and health information system. You know, in Indonesia, we still using this S2 since 2018. So it's mean health management information system escalate and nationally used for the reporting, dashboarding, and data warehouse. Currently, we try to show something 13 health information system used for the nutrition and Ministry of Health owned by, especially in Indonesia, and it's depending of the scale up and used for national, district level, and facility levels. The S2 is currently centralized hosted, and also 13 application or system also hosted in national scale up, and used by more than 500 district, more than 12,000 facilities, especially for the primary healthcare. Why for primary healthcare? Because 2020 we have transformation of the healthcare, especially integrated primary care programs national way up. And the challenge is about the fragmented data. So that's why we have to see how we can combine everything from national perspective and use for program monitoring and also the decisions maker. So there are 4 objectives here, especially this is 2 contexts I mentioned before about this is 2020 18, and until now we still using from national level perspective, and we use for the dashboard visualization, reporting, data warehouse, and from data integration perspective, also we collaborate with many entities in Indonesia. So we are improving the data accessibility from national and also for the perspective from facility level and avoid disrupting existing data entry workflow. So based on the use case, we have 4 processes, especially to identify of the metadata has been used and also still developed by Ministry of Health. So 3 themes about the data metadata, especially data elements or metadata, API, and also mapping to the SS2 of Indonesia. So those part I can say is like standardizations, and all entities, especially from technical directorate of Ministry of Health, helping us how we utilize from the standardization perspective, operational definition, and also collaborate with HIPS Indonesia. So the next phase is the scheduled data extraction. So it's mean after we modify our SS2, we integrate from the 13 system, and the technicals is must be managed by our Center for Data Information Technology team, is Ministry of Health team, and we just support from the behind on that. This is the sample of the integrations. Collaborate from many health information system nationals, and also put into the SS2 and share to visualization in the SS2 nationally. And this SS2 is used for program planning at facility levels by routine monthly meeting, and also district health office or province health office based on the nutrition or maternal and neonatal healthcare. And what is the result here? So this is only sample of the applications. Everything is localized. So it's mean previously since 2019 on 20, we are import the metadata from this is two repository. So it's mean we adopt our repository metadata to local context, especially with the application with Ministry of Health and also maternal and natal healthcare. So this is very important. We have to mention here, we not built from the scratch. We adopt from the this is two or HIP center from Oslo. And the condition is must be transformed, not only adoptions, but also to translate with Indonesia and add more contextual of metadata here. So what we are seeing now is about the dashboard. After we saw the metadata process, we want to see how we can utilize our data and information from facility levels. And this is the sample of the INC4 with INC6, especially in Indonesia. We can adopt from many kind of the data sources, and we can combine, and also we can analyze what's the weaknesses from this part. Is about the technology or about the program itself. This is the sample of the INC programs. In the second dashboard, I can tell you it's about the maternal and neonatal death notifications here. This is a sample what we are can see about number of babies, number of the mothers, and also number of the case based on the death notification or death type something. So this is a sample what we can see is not only from the nationals perspective of program. So facility district health office able to see of the Indonesian context now. So this is the sample of the delivery complications, a complication of delivery. And the data source from the 13 of the applications. The questions, how we can manage the quality of the data. We had we have some procedure about the data quality routine at facility level and district health office as well. So the key benefit here is we can combine from multi data source. Very important. So that's why we can reduce of the avoid of the multi entry or another entry on this program. Automatic consolidations for single dashboards. Every operational dashboard shared to facility and district health office. So that's why they can focus how they can minimize the problem of the programs, not only for the technology or the data. So improve data quality itself. This is part of the health program officer and also from data reporting officer at facility level and district health office. And we support of evidence-based policy and planning from facility levels. Data quality routine has been used by them and also district health office and national scale up. And what is the impact here? Access of the information for the stakeholders is near real time. So it means they can see and propose the program based on the current condition of the data. And supporting monitoring and evaluation across multi programs. We know maternal neonatal healthcare, they have their own indicators of program and also nutrition as well, immunizations, and from the facility readiness of health equipment also, they have to see the informations and contribute for the better health outcome, especially how to use unified health data programs here and step forward for national integrations of the Indonesia. And what is the conclusions? Also, to support of the integrations of the primary care health program, currently we are not only integrated from not integrating from the 13, but also to support of the more than 20 data source, such as from the another ministries and bodies, family planning, and also from the university secondary data, something like that. And now 3 people use for the dashboard in monthly basis. So we can monitor the users. This is the more technical, but we can see how they can more actively and improve the dashboard, improve the discussion about the data in this part or levels. And thank you. Terima kasih. That is from my presentation and team. Thank you.
Thank you so much. Thank you. Thank you. Let's get ready for our next presenters. Come on up. We have 4 presentations though, right? Do you have a, yeah, last one? Give me a test so I can see if I hear you online.
Yes, can you hear me? Good afternoon. Thank you so much. Good afternoon, everybody here in the room and to the audience online. I present this experience from UNICEF Uganda country office, but I present on behalf of the Ministry of Health and the EPI program of Uganda. This was teamwork that engaged the UNICEF Uganda country office under the lead of the Ministry of Health, the National EPI program, and the TA Essential, the technical assistance of the UNICEF HQ data analytics team. Me, I'm Fabrizio Baccaro. I work as an EPI officer in the UNICEF Uganda country office. So the problem we were facing in Uganda, in the national immunization program, was the need of improving the quality of our data, basically. We routinely use data for prioritization of interventions, but also prioritization of geographic areas where to support, and also to monitor the impact of our interventions, to see if what we are doing is working or not, and eventually to change. But even in our setting, we were acknowledging problems in data quality, also quite significant. And the example is here. We talked many times in these days during the coffee breaks with some of us about the so-called negative zero-dose children. So these children that we have, or apparently we don't have, when the immunization coverage goes above 100%, which is something quite common in some areas. And we see here in this district of Uganda called Kamuli, for 2023, a coverage of MR1, so the vaccine against measles, above 100%. But you can see on the right a little child with measles. And that was something we were dealing with, coverage above 100%, but still outbreaks of measles. And also we had an outbreak, thankfully only environmental, of polio last year that required a campaign with coverages above 100%. So in agreement with the colleagues of the Ministry of Health, we engaged our colleagues from our HQ to request for a TA. As we saw, they provided TA to our neighbors of Tanzania, and we reached to them to from New York, and we acknowledged the data quality problems were both in the numerator and in the denominators. The numerators, we focused mostly on the outliers, on the missing data, on the inconsistencies. So those implausible relationships between related indicators or antigens. And then we acknowledge the problem in the denominators with an old census that's dated 2014, growth rates that were uniform across districts, 2.9%, 3%, the same for all. And Uganda is also a country with a very, very high number of refugees that affects especially some areas in the north, those bordering with Congo and South Sudan. And this also affects the accuracy of the denominator if it's not catered for. So you see in this analysis that we made during the assessments, this is the chart of Uganda, and you see these ones in red are the districts with an immunization coverage for DPT1 above 100%. And so this was the main problem, and this is our initiative, the UNICEF initiative of advanced actionable health analytics for decision making, that is led by Maria Muniz, that is here in the audience. We started from here the work of data cleaning. The work of data cleaning, we focused, so we downloaded, here is where DHIS2 comes into game. So we downloaded data from DHIS2, we focused on 3 main indicators, so Penta 1, Penta 3, and those one of measles, MCV1, data from 2018 to 2024. And number 1, outlier detection. Here the interesting thing, we found that to make the outlier detection more accurate, the statistical team that actually Yoshito and George are also here in the audience identified this methodology of adopting 5 different methods for outliers detections combined in order to select only those values that were positive with more than one method of detection of the outliers. So this allowed us to identify the outliers. An example here with this facility that reported Penta 1 data with value of 14, 15, 14, 16, and then suddenly in September 7,780. So this was an outlier that required reaching the facility and correcting the outliers. And we did it with all the data set of almost 5,000 health facilities in this exercise. We downloaded from these 5,000 health facilities from 2018 to 2024 also the missing data. And wherever there was missing data, we reached through the Ministry of Health, the districts, through the districts, the health facilities. And the inconsistencies, the third parameter that we considered. Also, let me try my pointer. So for this facility, for example, in Kampala, Penta 1, 12 doses, Penta 3, 1,012 doses. That was a big inconsistency between these 2 related indicators. And all these data quality issues were addressed through Excel sheets, were downloaded from the HIS2 into Excel sheets and forwarded to the districts and to the health facilities, and were corrected. So this allowed us to improve the quality of the numerator. Second step, improve the quality of the denominator. We had multiple sources for the denominator. We had those coming from the census of 2014. We have other sources also from United Nations. Finally, we, in agreements, we identified that the most fit denominator was the one coming from the VUNIC estimates. And if you want to know anything more about the methodology, the VUNIC person is here, are here actually in this line, so around, so take the opportunity. This is something that we did, as different denominators also affect the coverage. And in the end, we used the denominator that was giving the lowest number of districts with coverage above 100%. So in the end, our map changed from this to this. And you still see there are some districts with a coverage above 100%, but they've decreased. So basically, we could have data that were more accurate, we assume. And still some districts were in red, but for example, this probably because of the refugee influx or some other reasons. But we had more accurate denominators. And the results, we have been able to get different coverage of immunizations, different from those that we had at the beginning of the journey. We got coverage for the national, and we see here so from 2018 to 2023, and then we added also 2024. So we see the trend. We see in 2020 the drop in the coverage. And we saw also, we extracted also for the regions, here for 16 regions. And within the regions, we extracted the trend from 2018 to 2024 for the districts. So that for every district we can know if they are improving or not. And in the end, we could also get the trend for the health facility in a second step. We extracted very different types of infographics. This one based that reaches, so from the regions to the district up to the health facility, compares the cumulative, so the relative change of doses for month by month, using as a baseline the 2019. So here for this facility, Tumu Hospital, we know that in 2021, as the color code is red, there was a decrease in the number of doses that of the same vaccine that have been given in 2021 compared to 2019, which is something that we don't expect as the population continuously grows. So we've been able to identify what are the facilities that are decreasing their performance and that require action. So this, you remember the first slide, actionable health analytics for decision making. So that was our goal. So after all this analysis, we tried to action this data, and we can show how we've used this. Here we see these two health workers. So at district level, this data can be used at the health facility level if they are there. A team must be there and must use them. But we take the example of Chenjojo because we shared this data with the districts. In this district called Chenjojo in Western Uganda, they analyzed the data, they acknowledged a decrease in performance, and they tried to do a root cause analysis to say, why are we performing not well? Why our performance is decreasing? And they identified three main causes in demand, a problem in demand generation, and they developed corrective actions. They found a problem in the financial motivation of the workers with delayed payments, and they found a corrective action. So they made a plan of action, and also a problem in planning and prioritization, and also loss of follow-up with a lot of defaulting children. And they introduced a child defaulter tracking register in the districts. And this is one of the actions. So this is an example of how the data can be action and can guide the decision making here at the district, but could be also at the facility level. And for us at the national level, we did the same sit with our technical working groups of the national EPI program, and we see the regions. I remember there was a region that was not performing well, and through these infographics was clearly highlighted, and we planned an intervention to improve the coverage, and we went ahead. But also through the ranking of the regions, of the districts, we've been able to use the results to guide the applications to request for international funds and resources to guide to improve the overall performance of the program and the quality of the program, and of course also to monitor the impact and the results of our work. We found some challenges, of course. By the way, it's always a cycle. So we spoke even in day one about how the data use improved data quality. Now data quality improved data use. some challenge that we would like to share and that we are trying to engage. Of course, the country must be engaged. The first thing is to acknowledge the problem and to be willing to do something. That's the demand-driven approach of the technical assistance that came from our colleagues of the HQ, and we need collaboration, national level, district level, up to the health facility level. This was kind of a problem when we went to the health facility level, was the delays in the data correction, especially when we first did the first analysis and we saw that we gathered data from 2018 to 2024. So there was quite a backlog that had to be addressed from the health facility teams that had some delays and also some, let's say, sometimes not good motivation in doing so. So that's also the challenge of engaging not only the national, but also the sub-national up to the health facility level, that are those that collect the data and then in the end have to correct them. But to let them understand how the data are used and how they can improve their performance, how they can improve the impacts of the program, this in the end, we hope will improve the overall uptake of this program. And yes, that's all. Of course, there are competing priorities, so that's also a challenge. But what we try to do as a data team, that is just one of the pillars of the API program, is to try to make data as one of the priority of the overall national API program. And so that was one of the corrective measures. Thank you very much. And we are here around for further questions.
Thank you so much to all of our presenters. We have just a couple of minutes remaining. So if anyone has questions, please let me know, or I'm also going to check the Zoom chat to see if we have any questions there. No questions on Zoom yet. Does anyone in the room have any questions for the speakers? You have a question? Okay.
Yes, thank you. I have a question to the Ethiopian team. Really great presentation and the model, particularly on planning. The quick question is, so once targets are set, so let's say I'm in a Kebele or a Warida and I've set my target and you've collated it at national level. Is there a chance throughout the year that the system is flexible? I can go in anytime and change that target, or there's a window where it is open once I put it in, it's locked? Thank you.
Thanks for your question. Okay, here we go.
Yeah, there is a window, a specific window initially, especially during the first phase of the first quarter. There is a lot of back and forth going on. So during that time, you can, but once that is passed, it's not impossible, but it's not allowed. But at the end, there is a small window of during a correction that you can do. Thank you.
It's a commitment by the Waradas and the Kabbales and the regions to achieve those. And if they are saying, depending on their performance up to some time, that they are going to reduce their target, it's not going to be genuine. So it's because of that. Yeah.